Thank you, Simon, very much. And it's really difficult talking after Karen because I'm always just blown away by Karen's presentations. The data is so clear. And what I thought I would do is try and kind of zoom out a bit to think about how we can think about this data and what its relevance is more widely for children's health, and where there are some opportunities, I hope, for us to think about in ways in which we might want to intervene. I think the first really important point is that Karen's obviously been talking about mortality, but she could have been talking about obesity rates. She could have been talking about oral health. She could have been talking about vaccine uptake. She could have been talking about exposure to polluted air. Actually, many of our kind of child health issues follow a very, very similar pattern. And I think the importance of looking at mortality is that it's kind of gruesome. You know, as paediatricians, we know that children in this country mercifully actually die very seldom. But we have this fantastic database that allows us to really, really drill into understanding in a huge amount of detail the reasons. And so I think, you know, as a paediatrician, I feel incredibly compelled to take this seriously and for us to try and understand and really get under the data and think as widely as possible about what we can do to intervene. So I wanted to start by reassuring you that the entire medical profession is appalled by the situation of child health in this country, and completely committed. And I'm talking about, you know, everyone from surgeons to adult physicians to psychiatrists to, you know, you name it. Everybody is on the same page when it comes to understanding and being deeply worried about the state of child health. So I draw your attention to these two documents. The first was published in the autumn of last year from the Academy of Medical Royal Colleges. And then the second, I'm sure you've seen, from the Academy of Medical Sciences from earlier this year, both saying pretty much the same thing, which is the fact that unless we wake up and understand just how perilous a situation we are in currently with regards to our child health outcomes, that we are really putting the future health of the entire nation at risk. And that sounds dramatic, but I'm afraid it really is that stark. I was, in my role as President of the Royal College of Paediatrics and Child Health previously, very privileged to be involved with the document Securing Our Healthy Future, Prevention is Better Than Cure. And I worked with Kevin Fenton, who you may know is the President of the Faculty of Public Health. And what we did was we pulled together some key childhood outcomes. We looked at oral health, we looked at obesity, mental health, vaccination rates and air pollution. And then we made the stark financial case for why intervention would ultimately reap reward for us as a society. And we also looked at the data that showed the stark differences across the indices of deprivation, very much as Karen's been alluding to with her mortality data. And then we systematically worked our way around all the medical royal colleges to get buy-in. Because as you know, we like to sort of sit in our specialty groups and I just talk about children and someone else just talks about mental health. But actually what we got when we worked on this together was all of the specialties sitting up, so, you know, adult surgeons saying there is a tsunami of problems coming our way. It's already, you know, kind of arriving, but, you know, there's worse to come. Because when you look at the data around, for instance, obesity in children, you know, the adult surgeons are recognizing that actually they've got major problems coming their way in not such a long period of time. And likewise, the, you know, psychiatrists and the adult physicians, everybody, when we laid out the data, you know, they kind of already knew it, but what we did was try and put it together. So we've got complete unanimity when it comes to the medical profession about just how worrying this is, and a real call to government to take this seriously, and a real sense that, it is much cheaper to invest in a healthy childhood and do that primary prevention work than it is to start tackling the problems when they're established in adulthood. Of course, there are huge arguments for secondary prevention in adulthood, and I'm not going to argue against that, but actually it makes far more sense to intervene really early on in pregnancy and in early childhood to get this right. And that is really how you invest in the health, well-being and prosperity of the nation, as the Academy of Medical Sciences said. So I think there's a really, really strong argument coming from the whole medical profession about this. I'm a massive fan of Professor Berwick, who you may or may not have heard of. Happens to be a paediatrician, but more importantly, set up the Institute of Healthcare Improvement in North America and has done a lot of work with the NHS. And this is how he's put it. The fact that it is simply not a smart investment to keep running healthcare as a repair shop, and that we have to do what Corin's been talking about, which is really, really try and think about where the real generators of illness, injury, injustice, and disability are. And then, as he put it, our children have only one future. And so this is a real wake-up call for us to really think upstream. And that is in childhood. And it's thinking about where we have these opportunities to try and intervene, to really think about where illness comes from. So Karen mentioned Core 20+5, and of course we shouldn't ignore it, because we need to work with structures that we've got in place. And of course, this is an NHS England programme, which started off with an adult programme, and then I think they realised they were missing a trick, which is why they produced the second programme, which is at the bottom of your screen, which is the one for children and young people. But I think the thing that I find most disappointing is that actually, on the face of it, none of the 5 or 6 programmes within each of the 2 Core 20+5 programmes is really addressing the issues that we're talking about today. Now, I have to say that Professor Bola Owolabi, who is the National Director for Core 20+5, is absolutely on the page with this. And we all sat down with her, and Karen presented the data, and there's a real commitment from her to use Core 20+5, which after all is the engine for helping the ICSs to really focus on health inequalities in their local geographies. And so we've got a real commitment from her to look at this in a much, much more detail. But as you can see on the face of it, there isn't actually any sort of work stream that's currently in place to do this. But I think that I was going to say beauty, it's not, the strength of the 2023 National Child Mortality Database is that it essentially is a wake-up call to say, hang on, there's a massive gap here, and we've got to focus. And Core 20+5 is one of the ways in which we can start to address this. What I thought I would just do is throw out just some other ideas that I've got about ways in which we need to think about these problems, because these are not easy problems, and whatever we might think about the next government, they're going to struggle as much as the rest of us with this, and particularly in the context of the fiscal environment in which we're working and living. We know there isn't a lot of money around, and so we have to think about how we can really intelligently address these issues. So I just want to touch on workforce data and technology, but I'm conscious of time, so I'll do this as speedily as possible. But I think we really do need to think about the workforce that we have, and there's absolutely no doubt that the health and care workforce has historically not really thought about the social determinants of health. This is quite a new topic. I can only speak for myself. I don't know. I guess Corin's probably from my generation. Sunil isn't from my generation, but I can honestly say, Corin and I went to medical school in South Africa, where my goodness, if the consequences of racism weren't hitting you between the eyes every single day, that was definitely an environment where it was blindingly obvious. But actually, we weren't talking about the social determinants of health back then, but we do now. And I think there's a much more knowledge about it. But we absolutely have to get it into our undergraduate and postgraduate curricula in a much more overt way. And I think talking to younger doctors, we talk about burnout and morale problems in our workforce. But actually, if you're in A&E and seeing the same kids coming in day after day after day with exacerbations of asthma, or with the kind of raft of presentations that we see that we know are strongly influenced by these social determinants of health, actually it becomes a really demoralizing environment to work. And I have a shrewd suspicion that actually a lot of our burnout and morale issues relate to the moral injury of working in a healthcare environment where we know that we are the 6th richest nation on the planet, and yet we're seeing day in and day out in our emergency departments and clinics diseases that we should not be seeing in this country. And so I think really raising the awareness of the social determinants of health is absolutely crucial. And one of the ways of doing this, I think, is around tackling differential attainment and really thinking about the people we recruit, particularly into medicine, but of course into nursing and the wider healthcare professions. Because we know that if you recruit a workforce from more deprived population groups, they're much more likely to work in those environments. And that's where we need our workforce to be working. So we need to be much savvier about the kinds of children and teenagers from the schools in which we recruit from, and really thinking about how we're tackling differential attainment. And then really proactively thinking about widening participation, because we're really missing a trick. We could massively upskill our workforce if we thought creatively about the young people that we recruit, particularly into medicine, but of course the wider healthcare workforce. And actually, if we did that, we would also at the same time improve our cultural competence, which would make us much more able to tackle these really difficult issues in a sensitive and thoughtful kind of way, and really start making inroads into these really difficult and intractable problems. So I think workforce is really important. The other thing we need to think about is how we deliver care. Where do we deliver care? How do we do it? And there are some examples around of people who are thinking proactively about how they deliver the care to their local communities. And I hope you're aware of the Lambeth Leap programme. It's an example. There are many examples around the country of groups that are saying, let me think really proactively about my local population. Let me think about what the data is telling me about where my stillbirth rates are highest, where my prematurity rates are highest, and really focus interventions specifically on those communities. That's what they've done in the Lambeth Leap programme. And the interventions are really simple. It's around caseload midwifery. It's around focusing on those most vulnerable populations. And in under 10 years, they've been able to show a reduction in prematurity, stillbirth, and intrauterine growth restriction. So we know that when you understand your local population, when you really drill down into your local data, with really quite simple and low-cost interventions, you can make a difference. And what's fascinating about the Lambeth Leap programme is that they've been able to show improved midwifery retention as well, because actually midwives like that kind of close relationship with their with the women that they work with. They look after them throughout pregnancy, they deliver their babies, they do the postnatal care. It's an extremely rewarding experience as a professional. The other thing we need to think about is how we deliver care and where we deliver care. And again, there's some stellar examples around the country of people who are really being thoughtful about identifying where the need is greatest. So I commend this group, which is Connecting Care for Children, which is based up in, came out of St Mary's Hospital in Paddington, and they're now examples. They've evangelized the child health community, and they're now examples of Connecting Care for Children literally all over the UK. But we need this to become the norm. This is about paediatricians and general practitioners and child health professionals and primary care professionals working collectively in primary care to deliver care to children and families in the community, in clinics that are set up to deliver care in the local community and they're educating the primary care workforce at the same time. So this is a fantastic way of delivering person-centered care in a locality and upskilling your workforce at the same time. So I think we really need to think about how we deliver care as much as anything. Leadership is crucial to this. And I mean, in a way, the leadership conversation is a talk in its own right. But, I think the only way we can do this is about really, really trying to think about how you work collaboratively. We work in very complex healthcare systems now. So it needs a very different leadership model to what we are used to. That kind of old-fashioned command and control way of doing things just doesn't work anymore. You really need that kind of collaborative, compassionate way of working in these very complex social and healthcare environments now. And we really need to be investing in leadership development, because otherwise we're just not going to make the kind of impact that we need to do. And Michael West, of course, has done some fantastic work, really thinking thoughtfully about how we lead in order to kind of bring around collaboration in these complex environments. I mean, this is what it's all about, isn't it? So this is not about egos. It's not about, one of us getting it right and all the rest. It's about, I'm here to get it right, not to personally be right. And so, I will often challenge people to say, actually, this is about a collective effort. This isn't about individuals kind of wanting to score points. It's about kind of really trying to understand these problems, bringing everybody, including our patients and children and young people, to the table to really try and understand where we need to act. Data is the next thing, and it's absolutely key. And of course, the National Child Mortality Database is a perfect example of this. But we ought to be doing much, much better in collecting data and then linking data in a really intelligent kind of way. And of course, we've got some absolutely brilliant examples around the country. The Born in Bradford program is the obvious one, but this ought to be just normal. We ought to be able to collect data and then use it to inform how we deliver our services. And so that when we're thinking about the kind of health outcomes that we're seeing in our A&E department or in our clinics, that we're not just thinking about it as a health issue, that we are able to understand, what that individual's housing is like, what their educational background is like, have they interacted with the criminal justice system, etc., etc. And at the moment, we're all working in these data silos, and it's incredibly frustrating for the kind of lost opportunity that we ought to be able to kind of lever, and which the Born in Bradford program has been able to show what we can do when you really can link data and then really think about how you lever improvement. And I want to give a shameless plug for the fact, for children, there's such a lost opportunity. Every child is born with an NHS number, but when they get to school, they get a second number, which is the unique pupil number. And we have this huge lost opportunity just to have a single number. Because if every child had a single consistent child identifier, which I think arguably should be the NHS number, we then enable it'd be so much simpler for the systems to start speaking to each other. And this idea that children's health and education is kept separate is just bonkers. Because actually, most of children's well-being sits within education. So to artificially separate it just makes no sense at all. So I think, in terms of a single policy ask, we really ought to be banging the drum for a consistent child identifier. And then lastly, I just want to mention technology, because I think, we are, it's 2024, there are a whole heap of tech solutions out there, but we need to be really careful as we think about how we use technology. And, as a paediatrician, we see all too often how technology is created for adults, and then there's just a kind of an assumption made that actually if you just make it a bit smaller, you can apply it to children, and then it's a bit smaller, and then you can put it on a baby. And the pulse oximeter is a classic example. And actually, if we're not thoughtful about how we use technology in children and babies, we're really, really missing an opportunity. And so there's a whole heap of work about really thinking about how we commission technology for children and babies, because I think there's a massive untapped resource there. But at the moment, it's not good enough to just slap an adult pulse oximeter onto a baby and expect that you're going to be able to use that and lever the kind of improvements that I think technology can deliver in 2024. But we're a little bit of a way off that. Pulse oximetry is just one example, but there are lots of others as well. And I think we ought to be really, put aside our egos. There's a heap of fantastic stuff happening in low-income countries, the kind of so-called frugal technology. There's some really interesting stuff about antenatal monitoring, for instance, that's happening in Tanzania, for instance, that we could be learning from and utilizing precisely in the kinds of environments and communities that Karen was talking about earlier. So I think there's a huge amount of kind of lost opportunity around technology, and I think we could be really, that could be a really exciting area that we ought to think much more proactively about. So those are some ideas. I think we've got a really imperative to tackle these problems. The challenge is huge, but what's so exciting is that actually we could make such a big difference, not just for children, but actually for the health of the entire nation. So I think we've got a fantastic opportunity. So thank you very much. Thanks, Sunil.
Thank